The most important transition in the care of locally advanced cutaneous squamous cell carcinoma in the last 24 months has been the advent of neoadjuvant therapy. And it relies upon the assumption that by providing systemic immunotherapy up front before a tumor is resected leads to a much more robust and variable T cell response, higher antigen load, higher variability for those T cells to adapt to, and can expand that clonal population and have a much more durable response after the tumor is resected. And in fact, we're seeing such remarkable responses that some patients are foregoing surgery or refusing surgery because they've had impressive results where it appears to be a clinical complete response. The challenge that we now face is figuring out what's going to be the next best step for those patients. Trials have been run where patients underwent surgery to be able to histologically analyze and confirm the pathological response. And we have long-term data that shows that those patients that have pathological response continue to have relapse-free survival now beyond 2 years. And it's really robust and impressive results for those patients on just 4 doses of anti-PD-1 systemic immunotherapy. As I noted, the challenge is going to be in understanding, does everybody need surgery? Can we have a surrogate marker for response and de-escalate care completely? And that's what I think the next 2, 3, 5 years will be to answer that question, so we know how best to utilize this medication upfront, as opposed to adjuvant, where we have potentially a smaller T cell profile. The tumor has been removed and we're trying to eradicate micrometastatic foci, or because of high-risk features, the patient is much higher risk and needs extra help beyond surgery alone. So 2 different diverging approaches, but really have changed and improved the outcomes for our patients.